So we're going to be going over multi-drug sedation, a little bit about drug potentiation and how that works, kind of what we're thinking about. And Neil, you're going to be a medic soon. I know you're thinking about nursing school, medic school eventually. You may even get stuck in the back of a critical care transport where we're dealing with these types of patients that they're very, very sick, and we need to keep them unresponsive. So first looking at the sedation score, how sedated do we want these people? And long-term school thought was a RASS of -2. And this is the Richmond Agitation Sedation Scale. It goes from a +4 to a -5, where +4 is violent, combative, aggressive. Typically, when we're looking at intubated patients, we are looking at somewhere around the +2 to +3, where they're fighting the vent. They're reaching for tubes. If you've been involved in intubated patients, you've seen them at BMH or Grace Cottage reaching up and trying to pull that tube out, or making purposeful movements towards that tube. And this is where that scale comes from and how we determine where they're at. And generally, anyone for intubation purposes that's above a -2, -1 needs more sedation. We want them unconscious, compliant, not fighting us. And we always have high risk events in and around intubated patients. We're moving them from the hospital stretcher to ours. We're agitating them. We have got a risk of them waking up and pulling things off. In the transport environment, we have the bumpy roads, we have the motion, sudden stops, sudden starts. All of that contributes to where they're going to be on the sedation scale. And it's going to be different in the back of a truck than it will be in the ER.
It's a controlled environment.
It's a controlled environment, exactly. The back of the ambulance is not a controlled environment. So what we're dealing with is that oftentimes on the front end, we do get inadequate orders for sedation, or the patient is inadequately sedated. That's not the hospital's fault, because they're right now in a sterile, controlled environment that there's no noise, there's no motion, there's no loud noises, there's no bright lights, and they're comfortable. So as they start adding these stressors, they start to get more agitated. So we do need more medicines to get them more sedated. Ideally, we want them between a -4 and a -5. So a -4, which is deep sedation, they don't respond to voice, but they movement and they eye open to physical stimulation very slightly, and then very rapidly, less than 30 seconds, they are back unresponsive. So very, very minimal response to stimulus. And then a -5 is they're down and out. They are not responding. Mark, where are yours? Where do you try and keep them usually?
I notice more and more of the orders, they are writing it to maintain a RASS of -3 to -5.
Uh-huh. Yeah, I mean, -3 is absolutely kind of the bare minimum we want to be in the transport environment. Because -3 is they do briefly awaken to eye contact to voice, but it's less than 10 seconds and then they're back being unresponsive again if you get rid of that stimulus. So indicators. The far left, you're my right, is the most serious. These are indicators for, so if you don't know the RASS scale or the agitation scale, you can use these indicators as a very easy way to determine, do they need more sedation? If they're coughing, gagging, or retching, these are your high critical events. They need more sedation right now. You need them to go unresponsive because they are an active risk to themselves, especially when they're on the ventilator. In the middle is our yellow, so not as risky, but we're becoming more and more concerned. They do need sedation, Not exactly right now, but within the next 2 to 3 minutes. So these are, if they start tearing up, we know they're in pain, and they're at risk of waking up now. If they're moving slight movements of their extremities or their head, we know that they're getting less sedated. And if the ventilator starts alarming, and we're looking at alarms of high PEEP or low PEEP, which means they're actively fighting against the ventilator and they're not in synchrony with it. So that means they're getting less sedated, they're not compliant with the ventilator. And then the green zone is we're stable, more or less. They may need more sedation, they may not. It all depends on their physiologic status. So tachycardias are a sign of pain, and having a breathing tube put in, having it in there is very painful. It is not a fun thing to do, especially if you've ever been bagged or you put CPAP on. It's not a pleasant experience. And now you're just forcing air into their lungs, and it's not negative pressure ventilation, it's positive pressure. So it feels different, it feels painful. Hypertension, so high blood pressure. And then we have uncontrolled overbreathing. So they may sync with the ventilator, but they're breathing faster than it and the ventilator is allowing them to do so. But if they're breathing over it, that means that they're not as sedated as they could be. And sometimes we want this, sometimes we want to take it away. So it all depends on where they're at, is if we want to allow this to happen. But the risk with hypertension and tachycardias are, what is their real blood pressure? What is their real hemodynamic status? So what if they're paralyzed? How do you know they're in pain? How do you know they're undersedated? We have to go back to that green and yellow criteria of they may tear up, the tear ducts may open up, they may become excessively diaphoretic, and the biggest indicators are the tachycardias and the hypertension. Those are going to be our most relative indicators of pain when they're paralyzed. What if they're hypotensive? We've got low blood pressure. Is low blood pressure a reason to not manage pain?
No, but it's one to be cautious with, because if you continue to lower it, you could have a deterioration of your patient.
Absolutely. You want to be cautious. So we should be looking at medicines that don't cause a hemodynamic change, medicines that will either increase blood pressure or will keep it relatively neutral. But just because they've got low blood pressure doesn't mean that we shouldn't manage their pain, especially if they're compliant on the ventilator. If they're paralyzed, then they are completely aware of what's going on. They're just not awake. They can't move, but they're completely fully aware and they're feeling everything, hearing everything that's going on. So if they are paralyzed, we need to be very mindful to keep them sedated and have them unconscious with medicines. So what if they become hypotensive? What's the number one cause of a patient becoming hypotensive after pain management?
Overdose, too much medication.
Not usually. Usually it's that the patient had an underlying hypotensive episode. And now that their pain's controlled, their body isn't trying to respond to that pain with an increasing heart rate, increasing blood pressure. So it's almost like a mask. Then we're looking at how fast was that drug pushed. Certain drugs, when pushed very quickly, will cause an immediate hypotensive episode. And then overdose, like you said, how high was that dose? Did it cause that blood pressure to drop precipitously low? For example, Propofol will cause hypotension. They'll rebound and come back within a few minutes, but it absolutely will cause hypotension just about every single time that it's pushed rapidly. So I like to go with an analgesia first approach. You have a blood pressure, and you're looking at sedation management. If you don't know if that pressure is reliable, especially if you're looking at the sedation that they currently have, and in the back of your head you're thinking, I don't know if this is enough sedation, this doesn't appear to be appropriate sedation, give them more pain meds. Control the pain first. Give them some fentanyl, give them a little bit of Versed, maybe increase the Propofol a little bit, and then you can adequately assess the hemodynamic status. You can adequately assess their blood pressure and heart rate because you've controlled their pain. And instead of being a mask, we're looking at what's really the underlying. kind of like Day of the Dead. You don't know what you get until you control the pain. Some patients, and Mark, I'm sure you've seen it, their pressures are upwards of 150, 160, but their profile, the reason they're intubated, doesn't correlate with hypertension. How often do you see that, Mark?
On a fairly regular basis.
Yeah. So we need to manage that pain first, then we can get a true window into what the hemodynamic status really is. So we've all heard they're saying that morphine is going to cause a blood pressure. It's basically a chemical bloodletting. We've all heard that phrase before, that idea. So opiates cause a histamine release. Similar to anaphylaxis, histamine is released, our blood vessels dilate, and now blood pressure drops. Well, opiates activate these receptors. The more histamine receptors targeted, you're going to get more hypotension. So looking at milligrams versus micrograms. So it's the actual amount of drug particles, the weight of the drug particles that are interfacing with these receptors. So milligrams, we've got morphine, Dilaudid, Demerol, or meperidine. Have we heard of those drugs causing low blood pressures before? What about fentanyl? Have we heard of fentanyl causing low blood pressures?
Every so often.
Every so often. And that's usually in higher doses. Because if we look at milligrams versus micrograms, micrograms are 1,000th of a microgram, or a milligram. So looking at vastly less particles, vastly less drugs, ultimately the fentanyl has a higher potency and a higher efficacy, but it's going to activate less of those histamine sites than morphine is. Average dose of morphine is 5 to 10 milligrams. Fentanyl is going to be 50 to 100 micrograms. So we're activating 1/10 of the receptor sites, or 100th of the receptor sites that morphine would activate. So we activate less histamine receptor sites, we're going to get less hypotension as a result. And that's why fentanyl is a safer drug occasionally for those patients. Now we're going to look at potency versus efficacy. Potency is how potent the drug is, what the concentration or dose is required to get 50% of that drug's maximal effect. That means you have half of those receptor sites are bound. Efficacy is the maximum effect. That reaches the point when you give drug, you give drug, you give drug, and now there's no additional benefit, there's no additional effect. It's just building up in the body, it's going to act as a toxin, but you're getting no additional sedation from it. Now we're looking at overdose or dose. So the purpose determines the dose. For example, 10 milligrams of Versed for anxiety is absolutely an overdose for that purpose. However, if a patient's having a seizure, 10 milligrams is the appropriate dose. So we're looking at dose versus overdose. We need to keep that in mind depending on what reason we're giving the drug for, what are we actually trying to happen. So single drug sedation, we use this all the time. Ladies in pain, we give them some fentanyl. A person seizing, we give them some Versed. But we typically require higher doses of a single drug for long-term sedation. So if we look at fentanyl, synthetic opiate, the benefits are you get respiratory depression. In this case, the reason we give the fentanyl is for added respiratory depression. It's a benefit in this case. They're intubated. It's not a contraindication that fentanyl will cause respiratory depression. If anything, it's going to help us out and keep them synchronized on the ventilator. It provides analgesia in sedation, where sedation is used to determine and refer to unresponsiveness, and analgesia is used to discuss pain management, the amount of pain it's affecting and reducing. So a typical dose for IV push is going to be 25 to 100 micrograms, single dose, or 1 mic per kilo. And an average infusion rate is going to be 25 to 200 micrograms per hour, or roughly 1 mic per kilo per hour. And if possible, we should be looking at bridging towards an infusion because it gets rid of valleys. Peaks and valleys aren't beneficial for us. So we're going to be looking at Versed. Versed provides significant sedation, a lot of analgesia, and also provides amnesia. It's a benzo, so it also causes smooth muscle relaxation, which can be a problem for us if it causes muscle relaxation, because we can get hypotension as a result of Versed and benzodiazepines. It works against hyperthermia by reducing that shivering factor, which is going to increase temperatures. Typical dose for IV push would be 5 milligrams. And then as an infusion, 1 to 30 mg per hour. So it's a pretty big range there. It all depends on what the patient needs to maintain sedation. But it can cause hypotension. There's a risk of the Versed. Next up we have Propofol. Propofol is purely a sedative. It's kind of jokingly referred to as the milk of amnesia. That's all it does, is it makes the person unconscious. It doesn't control pain. They can still feel pain. Very frequently we have patients in the sending facilities that are only on Propofol and at very low doses just after they RSI'd them. And that's because they don't exactly realize that they paralyze them. So they're not going to show these signs of reaching, grabbing, coughing, gagging because they physically can't. So again, Propofol at very low doses makes them feel good, but it's really not doing anything for the patient's benefit. So we can increase that, but just know that as you increase that drug, it's only going to work on unresponsiveness and sedation. It's not going to cause control pain. Mark, how often do you see Propofol only as a sole agent?
It's pretty common.
Yeah.
It's pretty common.
And I'd say it's grossly inappropriate to have Propofol only as an agent for interfacility transport. And it can cause massive amounts of hypotension. Ketamine. Using this more and more. Sedative hypnotic as well as an analgesic. It causes dissociation, kind of in La La Land seeing dragons. And they are unresponsive. Lights are on, but nobody's home. For push dose bolus, and this is not for chemical restraint. This is not for pain. This is for the purposes of maintaining analgesia and sedation long term. So 1 milligram per kilo IV push, and as an infusion, we're looking at 2 to 5 milligrams per kilogram per hour. Pretty high doses, pretty high amounts of medicine, but it's safe to go that high. And the benefit of ketamine is it's going to have bronchodilatory effects. It's going to open up those airways, and it's also going to increase blood pressure. So in that patient that has a blood pressure that's pretty low, we can give them ketamine, and as an added benefit, we're going to get increased blood pressure. So that'd be the drug of choice for that patient that's kind of circling the drain, blood pressure is not doing so great, and we still want to get them sedated. But now we're going to start mixing these cocktails together, causing a coma cocktail, so to speak. And what happens is they have potentiation. So a lot of these analgesics, they bind with plasma proteins. So that's predominantly albumin. And we also have alpha-1 glycoprotein acid. So fentanyl is pretty high, plasma protein bound. Ketamine, not so much. Versed is, again, very high. And Valium is also very high. I couldn't find numbers for Propofol. Mark, do you know what if Propofol is plasma protein bound? Yeah, I couldn't find anything on it. But I know that these four, they're common ones that we have for sedation. So these drugs bind to plasma proteins first. And we've all probably heard that you give fentanyl, you give Versed, they're going to potentiate. They're going to have a synergistic effect and have a net result greater than each individual result combined. Receptor sites are not activated until proteins are fully saturated. And that's key. So albumin has a low affinity, high capacity. Alpha-1 acid glycoprotein has a high affinity and a low capacity. Either way, these drugs are binding these plasma proteins first, and then they're going to bind with the receptor sites. In addition, we need to think about that these drugs are always trying to reach equilibrium. So the bound drug that's either bound to a receptor site or that's bound to a plasma protein, is equal to the amount of unbound drug in the body. So you give 10 units of drug A. Depending on, it doesn't matter how many plasma proteins there are, it will try and bind out 5%, 5 will be bound, and 5 will be unbound. It always wants to reach equilibrium within these compartments. So we have our protein there, we have our receptor site. We give 2 units of drug. One gets bound, one stays unbound. And everything out here is kind of existing in the plasma, just existing in the blood, not attached to a receptor site within that compartment. So we give some more, and we still have no effect at all. We give some more, and there's still no effect. We give some more, and finally here we have all receptor sites activated. This drug is fully saturated in the plasma and in the plasma proteins. So now we give it a little bit more, and it finally starts to get bound to the receptor site. We start seeing an effect. So what happens now we have this effect, we go ahead, and we'll just say that this is fentanyl, for example. We're going to go ahead and give 4 units of Versed. So you give 5 units of Versed. Initially, they just go into the plasma, and now they start to try and reach that equilibrium. So, because Versed is also very highly protein bound, it's going to kick 2 of those fentanyls off of the plasma proteins. And then what we have left over is going to attempt to bind to these receptor sites, because now that that's fully bound, that plasma protein is fully bound, everything attaches. And what happened was we had 3 of these fentanyls were out in the plasma space. Well, with that protein is fully bound, we want to reach equilibrium between bound and unbound drug. So now they're going to attach to the receptor sites. So now we had 3 fentanyls that were initially attached to proteins that are now available for attachment to receptor sites. And that's how that potentiation effect happens. Any drug that's attached to the receptor sites gets kicked off and becomes available to bind with the receptors. So that's how we get that synergistic potentiation effect. And that's important to be aware of as we start adding multiple drugs. Yeah, what's up, Niels?
So if you can go back just one slide.
You won't let me.
So when you have like Versed, like comparing fentanyl and Versed when it's going to attach to the albumin site.
Yep.
Is Versed more affinity, and that's why it's bumping the fentanyl off?
Yeah, so think of it as Narcan and heroin.
Okay.
Narcan kind of bumps it off that receptor site, and instead it bumps it off the plasma protein site. But it still wants to reach equilibrium, so the fentanyl is still going to compete to bind back to that plasma protein. So they're going to kind of reach equilibrium. All the Versed not going to attach to that receptor site and kick all the fentanyl off. There's always going to be a little bit here, a little bit there. But they're all trying to kind of compete. If you give ketamine, maybe ketamine might kick only 1 fentanyl off of that receptor site because ketamine is only 47% affinity for the proteins. And some drugs aren't even bound in the plasma proteins. Some drugs don't bind to these proteins, and they're available immediately for receptor site activation. For example, like adenosine or epinephrine. I don't think those are plasma protein bound. I'll have to double check on that. But they have immediate access to these receptor sites.
Or like Propofol. So because it's not.
I'm not sure if it is or not. So we need to look at compatibility, because now we've got multiple drugs going in, potentially the same IV site, multiple IV sites. So we should have multiple IV sites. When in doubt, get another one. If they have a central line, that's our ideal circumstance. We've got 3 ports on that. A triple lumen IJ is definitely our preferred central line, as opposed to a single 20 gauge peripheral. But sometimes they don't have that luxury, and we need to look at compatibility. These are definite compatibilities. Fentanyl and Versed are compatible in the same line. Fentanyl and Propofol are compatible in the same line. Ketamine and Versed are also compatible in the same line. Ketamine and Propofol are compatible in the same line, as well as Versed and Propofol are compatible in the same line. What we're not sure about, and I can't find any research on this, Mark, if you know better, let me know. I can't find anything about fentanyl and ketamine being compatible. I have an app on my phone. The physician's drug reference is a pretty good guide as well, but we should be checking compatibility before we just say, oh, it's clear drug and clear drug, this is going to be fine. Well, certain drugs aren't compatible. You take sodium bicarbonate and calcium, you put them together in the same line, and now you get a bunch of crystals. And now you've got particulate matter going into the person's veins, and you just killed them. So that's something we don't want to do. Just because both drugs are clear doesn't mean that they're going to be compatible together. Mark, anything that you have on compatibility?
No, and I guess one thing I would add, the hospital can always rapidly, because they're constantly checking it, or they call up to the pharmacy.
Right.
The pharmacist checks right.
And so using that pharmacist reference, or that I think Up to Date has a checker on it too, doesn't it? Maybe.
Yeah. But a lot of times they'll call right up to the pharmacy and they'll say, we need to know quickly, is this compatible?
Right, and they'll check that for you, see if they're compatible. Make sure it's also compatible with the IV fluid you're running in, because if all these are compatible with normal saline, but if you have LR, it may not be compatible with that. If we get into a saline shortage again, we're running either like Plasmolite A or Normasol, they may not be compatible with those either. So even though they're isotonic solutions, double check the compatibility with the base solution too, just because we don't know. Most things are compatible with D5W, most things are compatible with saline, but if we're running blood products, nothing is compatible with blood products. Like those need to be by themselves. So to infuse or to not infuse, are we going to do push dose meds, or are we going to give an infusion? Push dose meds cause hills and valleys. And when giving push dose meds, we're trying to time the next med before it gets in the valley. We're trying to catch the decline and then bounce it back up. Whereas if we have a infusion, we can maintain that indefinitely. Just steady level of drug in the body that's available for binding. And by doing an infusion, we avoid these hills and valleys. And each one of these valleys here, we should look at it as a death trap. That is the highest risk that patient has, is when our sedation hits a valley and we aren't aware of it, especially when it comes towards moving them from stretcher to hospital bed to stretcher, those critical moments of patient care, and we don't realize that we're in a valley, then things can be very detrimental. We need to keep in mind that, especially Jason as kind of our partner, if you're driving on this interfacility or you're the second person back, and I tell you that I gave fentanyl an hour ago, you should be looking at me saying, hey, do you want to give me some more? Want to give them some more fentanyl? They're going to be in a valley now, that drug's probably worn off. They may not look it, may not realize it. The heart rate may have come up a little bit that we didn't quite catch. The blood pressure may be rising slightly, we didn't quite catch. And they're in a valley, we move them, they reach up, grab the tube, and they pull it out. Especially at Dartmouth, one thing I always bring in with me is I always bring my NARC box in with me whenever I go in on a vented run, because I want to have additional sedation available if we need it. The biggest risk to that patient who's intubated and on vasopressive agents and sedatives, biggest risk is we don't have enough sedation, they pull the tube out, because we can't re-RSI them in the back of that truck. If they go hypotensive, we can give them drugs and fix that. If they go into cardiac arrest, we can give them drugs, electric therapy, and fix that. But the one thing we can't do is we can't reintubate them with RSI if they pull that tube out. If we lose that tube, we're done. We're absolutely screwed. Fentanyl has about a 30-minute half-life for push dose. Per protocol, we're allowed to dose at 5-minute intervals between 25 and 100 mics of fentanyl. Versed has about a 60-minute half-life. Dosing is at about 15 to 20-minute intervals. Propofol, we can titrate that up or down every 5 minutes as needed. by either 5 to 10 micrograms per kilo per minute. And then ketamine, we can redose the push dose every 30 minutes if we need to, or more frequently if we have to, but really we're dealing with multiple drugs of sedation here, so we've got enough agents where we can mix and match. We can make things work. Now we have the gray areas. Gray areas are maintenance of paralysis. Per Vermont protocol, it says maintenance of paralytics, and that's it. This can mean two things. It can mean that we have a continuous paralytic infusion, but one could also interpret that as push dose paralytics as needed, because it purely says maintenance of paralysis. The other gray area is maintenance of propofol. Propofol as a drug, using it as intended is as an infusion with push dose boluses as needed to maintain sedation. However, the maintenance typically refers to a straight infusion. So these are gray areas where we can get into trouble if we need to increase the propofol rapidly. Do we push a bolus? Do we push a little bit of saline into that line? Or do we increase the rate for a rapid flow? Really can't say either way because the state doesn't give us clarification. That's kind of up to provider preference. Same thing as the maintenance of paralysis. Mark, what's your take on paralysis maintenance?
On the propofol issue, that has been adjudicated. That's been allowed by waiver, so a bolus can be given now.
It can be given by bolus now.
Yeah, so probably Eric should send something out on that too. But,
Is there a recommended dose on that, or
it would really be
physician?
guided by an order.
Uh-huh.
So if you have someone on Diprovan, it's probably a good idea to ask, if I have to bolus, how much do you want me to bolus?
Right.
Yeah.
I mean, usually 2 to 5 mLs is more than enough to get them resedated.
Right. And then if somehow it slipped by, I'd get on the phone right away and call back and say I got to rebolus.
Perfect. So now that's been adjudicated. That's nice. What are your thoughts on paralysis maintenance?
That is a gray area. My assumption was that originally it was with a continuous infusion of a paralytic agent.
Right, like typically like a vecuronium.
Not bolusing unless you are RSI sanctioned.
Correct.
So, yeah, that one's as clear as mud.
It's very muddy because you can take maintenance as how is the drug intended to be used, and you can maintain that drug as it's intended to be used, maintain paralysis. And we're not an RSI service here, so we can't just RSI them. We can't push a bunch of sedation, give them paralysis, and intubate them. Just like we can't give them a bunch of medication-enhanced intubation either, so MEI. We can't give them a boatload of Versed and fentanyl and then intubate them. That's also not allowable under current protocol. But these are kind of the things that we're thinking of in the back of that truck is how do we keep them from pulling their tubes out? And that is by far kind of the riskiest business. You look at your thinking, Jason.
Mm-hmm. Just trying to do it.
Yeah. Niels, what are your thoughts being a medic student, being kind of on pace to get your medic in February, March timeframe? I mean, you wouldn't be taking these patients solo off the bat, but you very well be maybe second and back. Honestly, managing infusions.
It's one of those things that we don't talk about a lot during class because a lot of the focus is on emergent setting of managing patients emergently.
Right.
We're in the field, we've given a patient presentation, how do we manage them, because that's most of what we do on a day-to-day basis.
Yeah.
But in a service like ours, where we're taking runs like this frequently, having something to practice with would be good, especially for folks that are on the newer end like myself. Because I'm mildly familiar with most of the stuff for sedation and paralysis as part of like the meds that we're required to cover per the national standard. But because we don't use it frequently and it's not something we simulate with frequently, it's not something that I'm all that comfortable with using. Like I
Right.
wouldn't know how to titrate a propofol infusion just
Right.
off the bat.
And then you add in vasopressors, you add in multiple other agents that are trying to keep this person stable, critical but stable. It's kind of the term I've been using lately for these patients is they're stabilized through intervention, but they're still absolutely critical patients. You may be managing 3 or 4 infusions, maybe 5 infusions as a brand new medic. With me on the ventilator, Mark on the ventilator. There's a lot of kind of talking back and forth, trying to make a plan, formulate a plan. Fortunately, we're not alone. Like there's a reason that we send 2 providers on these patients, and this is one of them. Worst case scenario really is kind of towards the lines of the ventilator breaks and the pump breaks at the exact same time. And what do you do then? You got to pop them off the vent, start bagging them,
Start doing that.
get rid of the pump, start push dosing meds to keep them unconscious. Meanwhile, you're trying to fix the pump to get continuous sedation on board, and you're trying to fix the vent to free up that hand from the bagging. That really is kind of the worst case scenario, is things just start going wrong all at the same time. And now you've got 2 providers that are relatively busy. Fortunately, it doesn't happen very often, and on most of these runs, you might change a couple settings here and there, titrate a few medicines here and there, and you kind of sit back, you watch the vitals, you watch the trends, read the paperwork, and try and see what else you can do to optimize what you're doing. But every now and then we have a real train wreck, and both providers are pretty busy. How often do you think we get those patients? Mark, you see the data that are the real complete train wrecks.
30 patients, there's 3 or 4.
Yeah, that many.
Yeah, that there's an issue where something has to be done.
And the providers are relatively busy in the back trying to, yeah. And then we look at the case of when do we not want to paralyze? There are certain patient profiles that we shouldn't paralyze. You've got a 20-year-old. They got diagnosed with diabetes a month prior. They're not doing a good job managing themselves. Blood sugar's 800. They came in a diabetic coma. They're now intubated. Before they were intubated, they were breathing at 50 times a minute. Do we want to paralyze that person?
No.
Why no?
Because once you put them on the vent, you're more than likely reducing the speed that they're breathing at. So
Correct.
by cutting that back, you're reducing how quickly they're trying to balance off their acidosis because the body's not compensating as quickly as it needed to before.
Right.
When you take away the paralysis, you're putting the rest of the body at rest as well. So there's no further metabolism happening, which will slow your long-term buffer system down. So when you paralyze them, you're effectively reducing any chance they have of re-equalizing.
I'm compensating, yeah. So this is one of those sweet spots with a true metabolic significant acidosis where we've got meds running for sedation, but we need to find that sweet spot. And that sweet spot isn't maybe a RASS of -5. At a -5, they may be not helping out to contribute at all. I can set my rate on the vent at 30, but it's probably better for them if I set it at, say, 20 and let them contribute 10. Because their natural intrinsic breathing is going to be a lot more comfortable than my vent breathing for them, especially at a fast rate. So I can bring my rate down, and I can let them help out a little bit. They want to help out. Their body says, breathe fast, blow that acid off. I want to help out. So that's a case where paralysis may not be the best option. And true deep sedation, where you can drop a hand grenade next to them and they don't even flinch, may not be the best option. You may need to just be okay with them overbreathing a little bit and let them help out. Ever breathing by really up to a third of your respiratory rate, that's fine. If it's set at 20, they're breathing at, I don't know, 25, 27, and it's helping them. They're putting their CO2 in the right range. It's not a bad thing. Let them do it. That'd be a case where you may not want to paralyze. Mark, what are your thoughts on?
I would agree with that.
Yeah. Too often, especially as a relatively newer critical care level service, we want to have them completely down and out, and we're not comfortable with the patient breathing on their own at all. They breathe on their own. There's a patient-triggered event every now and then. That's fine. As long as they're not moving, they're not grabbing their tubes. You can just let it happen. And let them breathe on their own. Another case that we're going to be seeing that we don't want to paralyze them are seizure patients. If we paralyze a seizure patient, can we tell if they're seizing? No. We got no idea. Their brain may be doing that firing and burning up, but we will have no external indication that they're having a problem. In that case, we need to go down alternate pathways to control that seizure. They're paralyzed, will never know they're seizing. Maybe a short-term paralytic for initial intubation, but we shouldn't be doing long-term paralysis, especially during the transport, because we won't know if they're seizing or not. And we need to get that seizure under control.
Now, how does that play in when you have, say, a versed drip? So you know
Sure.
that they're, they come in, they're presenting as a seizure patient who's in status epilepticus. You've already assigned them with a short-term paralytic. The paralytic is now past its half-life stage, so you're fairly confident the paralytic's worn off.
Yep.
You're using the versed for sedation and hopefully as well for seizure control, but you're still losing the ability to, in the process of you maintaining that sedation, are you losing the ability to check if they're seizing or not?
Not really, because benzo is kind of the first line for seizure management. So if they're on the versed drip, it's not going to, if they have a seizure and they're on the versed drip, they had a breakthrough seizure. They broke through the medicine they're using to control seizures. If they're not seizing, it means it's controlled, because the versed is going to raise that seizure threshold. They're not going to seize. It's going to cause that relaxation, reduce that neurofiring. Now, if they do start to seize, there's a few options. One of them would be to know that they're on the versed drip and give them maybe a half dose of IV push versed, maybe a full dose would be kind of get on the phone real quick, call the physician if you don't have orders preset. I'd be looking at a half dose of the versed, so instead of giving 5 IV, I'd be looking at 2.5 because they're already getting a bunch on board. Or I'd be looking at starting another adjunctive agent. Maybe looking at phosphatidylcholine, maybe look at Keppra, maybe look at some phenobarbital, because we want to break that seizure. And if they're already on the versed, then we need to control. Clearly the versed is not working, so we need to try something else. Mark, what are your thoughts on?
I agree with that, because versed is really designed to break skeletal activity with a status seizure. There are much better anticonvulsive agents like Keppra and either phenytoin or phosphatidylcholine. A lot of times we'll take a seizure patient out and one of those is still infusing. Usually the Keppra is on board, a gram is in fairly quickly, but another agent if they're really concerned about seizures.
Yeah, and I mean, that'd be critical care level. Regular medics can't take those medications, but the critical cares can take them. They can just give us a bag and say, you can start this if you need to. Absolutely worth thinking about. Because there are cases that you don't want to paralyze. And sure, the helicopter has a 30-minute or 28-minute flight to Dartmouth. We're potentially stuck with them for, I don't know, a couple hours at most. Mark, what's the longest IFT you've done with an intubated patient?
I haven't taken anyone to Boston, so been to Bay State, Dartmouth, UMass. That's about as far as I've gone.
Yeah. It's not fun having them that long, is it?
No, because it brings up an issue. You have to really do the med math to make sure you have enough supply.
Right.
So I always go for 1.5 times what I could possibly need for the transfer, because a lot of times we're even hung up at the facility waiting to transfer the patient. So
Right.
you're consuming med during that whole, just like your gas reserve, if the patient's vented or on BiPAP, you just burn through that stuff like crazy.
Yeah. I mean, that's something that you guys could even recommend too, is you get them moved over, get those vital signs, initial vital signs, and then we're working on kind of setting up the vent, putting them on the drugs. If you just glance up at the supply, it's like, hey Jeff, hey Mark, your propofol's pretty low. Your sedation agents are pretty low. It's like, oh yeah, no, that like we appreciate that kind of stuff that we don't always think about. Sometimes we get caught up in the moment and don't always double check the supply, and then you realize when you're out the door, oh shoot, that bottle's halfway empty. I'm gonna need more than that.
Yeah, and Diprovan is really dangerous because it's only 100 mLs and it's so deceiving. People eyeball the bottle unless you really look at the pump, and they're very accurate about telling you like how many times they bolused or if they opened it up at a wide open rate to kind of give the patient a little bit more Diprovan. It's kind of hard to tell exactly how much is in the bottle, so you could get caught. I actually remember a patient last year that they ran out of sedation. They were like racing to get the patient inside because the propofol was about ready to run out.
Yeah, I mean, if you run out of propofol, you have to very rapidly switch to a different sedative agent. And depending on what you've got for options, you need to get that loading dose on board, get that initial effect, and then you can start your infusion. So we're dealing with kind of potentially very detrimental side effects of running out of a drug and not prior planning having things ready. And you can set up a ketamine infusion in a few minutes, but when that propofol infusion runs out, that's all you have are, if you're lucky, you have 2 minutes. That's if you're lucky. Sometimes I start waking up immediately. And that's the dangerous part about propofol, is that like I've gotten into arguments at the receiving facility. They'll say, yeah, you can shut your meds off. And I'm like, no, they're not getting shut off. Like, you have yours ready. I will stop, we will transfer, you will start. Because I've had patients where we've stopped the sedative agents, the propofol, and then they've struggled with the transition over, and they're waking up halfway through that transfer. So that's one thing that I really don't compromise on. Like, the first thing what I do when I walk into an ICU room, say, I've got this and this for sedation, you may want to get some right now. And we won't transfer until they're ready with their sedation, because that, again, the most dangerous part is during that transfer, they pull that tube out, there's detrimental side effects. They're a tube for a reason. No one is really a tube for being an asshole, with nothing wrong with them. Happens occasionally, but not very often. What other questions do you have? Thoughts?
I would like to start doing some stuff like mock-up scenarios of like, we've got SimMan vented, this is the meds that we're running, and this is how, in the event that we need to increase sedation, this is like the math processing and stuff like that. So that
so you're talking like doing more tabletop type stuff.
Yeah. Or even just like a hands-on simulation too,
Yep.
Because sometimes you need to know, like, all right, how long is it going to take me to make a Versed bag? Like, the process of pulling it from my NARC kit, making the, that's all a time,
It takes a lot longer than you think.
Right. And as we were going through simulation for clearing for field time, that was one of the things of like, all right, run a code. And it's when you think you have more time, and it's really, all right, I have 2 minutes to drop 3 meds. And then I have another 2 minutes maybe to set up my tube kit after I push my meds, so I'm already running behind on the next thing I have to do.
Right.
So
it's the time management aspect of it.
Right. So having an actual hands-on simulation would be great, especially for stuff like this of like, all right, I know on my clock, like I have 30 seconds before my propofol runs out, and I need to bolus something else. I need to troubleshoot and come up with a game plan on the fly, or have something preset so that I'm ready to roll with it.
Right. And One thing that's nice about Hal, now that once we get Hal set up and we start using Hal for simulation, is he can physiologically recognize drugs. He can pre-program drugs in the system with a volume and concentration, and he'll have a physiologic response to that drug. And if you stop the drug, he'll have a physiologic response to when it comes off, when it stops working. So as far as push dose boluses, is that accurate, Mark, that we can set Hal up?
The only thing I think we'll still have to have table med calculation, because the one problem with Hal is it's preloaded syringes.
Right.
So it's kind of fake. It takes out the element of having to prepare it and draw it up. The syringe is prepared in advance and it'll give you concentration, so you know in a 10 ml syringe you have 500 milligrams of med. That makes it kind of easy.
Right.
The much harder thing in real life is to have to physically go to a bottle, get the right bottle without destroying it, select the right syringe and needle, draw it up, and then do the math on it, all that. Yeah.
Absolutely.
And that's something that I want to be doing and like practicing, like having dry runs. So like, all right, we're anticipating worst case scenario and we're practicing for it before we get dry.
And then he can't do infusions, can he, either, Mark? You have to kind of manually program an infusion type in. If you were to put him on like an epi infusion, mock epi infusion, you have to manually change the parameters that he'd be responding to that way. Like increase the heart rate a little bit, increase the blood pressure a little bit.
Correct.
That makes sense.
Yep. Yeah, as an example, in our system, I'm looking for the med, where it is. So there's something missing from the NARC box, which would be midazolam. That's the #1 thing when there's a med error in the system.
In the Versed,
One, because we carry 2 different concentrations.
Right.
And especially around pediatrics, people don't use the length-based measuring tape correctly.
No.
Or use the app to calculate the dose correctly. So they're giving an excessive amount of it.
And is that usually an overdose on the Versed, Mark, that their patients are getting, or is it an underdose?
It's usually an overdose.
Uh-huh.
It's usually an overdose. Where they're, for example, in a pediatric, giving an adult dose.
Oh, no.
Because they don't put 2 and 2 together.
Oh, no.
It can be an issue on pediatrics, for example, because the volumes are so small.
Right. Yeah, actually, we do have 5 and 5 of the Versed, and we do have the 5 and 1. We really should have both concentrations available.
Yeah, you have the right tools for the right job.
If you only have 5 and 5 Versed, you can't give it nasally. You can't give it muscularly. It's not going to be an option. Same thing that's changing that we need to keep an eye out for is the ketamine. There are 3 concentrations of ketamine that I am aware of. I know that we have 2 that are circulating around our trucks. One of them is 100 milligrams in 10 mLs. The other is 50 milligrams in, I think it's 10 mLs. Or is it 5 mLs, Mark? I think it's 5.
Yeah.
Oh, yeah, it'd be the 5 and 5. So it'd be 505.
Where they're trying to standardize Pyxis, so the only thing you can get out is the 500 milligram.
In the 5 ml.
File,
right.
just to eliminate the error, because they've had some egregious
Right.
issues with ketamine overdosing.
And then I've also seen, I haven't seen it here, but there is a 25 milligram and 5 ml concentration that exists as well. So ketamine and Versed are the big ones that the dosing, the concentration does change. Just be aware of it. If you see an orange top Versed, it's 5 milligrams and 5 mLs. The green top Versed is 5 milligrams and 1 ml, typically.
For now, so.
Exactly, for now.
Just manufacturing.
Yeah.
Oh, yeah, because midazolam gets used all the time around here.
Oh, yeah.
I'm surprised I missed that.
Yeah, it's a very common medication. Anything that you want to add, Mark, about anything?
Going back to practicing, even with a pump, it's always good to remember med math, because the one thing, if you adjust a dosing schedule, a lot of times it's written for a range to maintain a map of. Let's say it's running at 20 mLs an hour, and that's giving you 150 mics, and you want to adjust it so it goes to 275 mics. You sort of have to be able to validate what the pump is telling you, because you could inadvertently put in an incorrect parameter. And a pump is only as smart as what you put in for numbers.
Right.
So if you make a mistake, the pump won't realize it's a fatal error. The only way to safeguard yourself is to be able to do med math and know, okay, it should be this quantity of mLs per hour to give this dose. Is that kind of
Yeah.
check and balance?
One of the things that they taught us in school was like, all right, we'll teach you how to do a pump, but it was much later in pharmacology with like, if you're gonna do an infusion, this is how you would do an infusion with a drip set over a set amount of time.